Your patient's cholesterol looks fine, but they just had a heart attack at 48. And here's what you might be missing. Lipoprotein little a or LP little a is one of the most underdiagnosed cardiovascular risk factors out there. It's independent of LDL, it's mostly genetic. And until recently, guidelines didn't even recommend testing for it, but that's changing fast. So, what is LP little a? Think of it as an LDL particle with an extra protein attached called apolipoprotein little a that makes it more pro-inflammatory and more thrombogenic than regular LDL. About 1 in 5 people worldwide have elevated levels, and elevated LP little a can double or even triple your risk of a heart attack, independent of everything else on the lipid panel. And the kicker? Diet and exercise have virtually no effect on it. It's 70 to 90% genetically determined. So lifestyle counseling alone won't move the needle. The 2024 National Lipid Association update and the 2025 European guidelines now both say measure LP little a at least once in every adult. That's universal screening. The high risk threshold of 125 nanomoles per liter or 50 milligrams per deciliter. Above that, you need to act. Now, here's a clinical pearl that most people miss. This is very important. Repeat the testing at menopause. The 2024 National Lipid Association specifically calls this out. Hormonal shifts around menopause can change LP little a levels enough to matter clinically. So if you tested a woman at 40 and now she's 52, check it again. The same goes for patients with declining kidney function. LP little a rises as GFR falls. Now, since there's no approved drug that specifically targets LP little a right now, the guidelines are very clear. Your main lever is aggressive LDL lowering. For high-risk patients with LP little a at or above 125 nanomoles per liter, the NLA recommends intensifying LDL-C lowering. Targets under 70 milligrams per deciliter for high risk, under 55 for very high risk. And the 2025 ACS guidelines go further. If your patient has elevated LP little a and their LDL is between 55 and 69, that's still a reason to intensify therapy. Step 1, maximally tolerated statin. Step 2, add ezetimibe if LDL-C is 70 or above. Step 3, PCSK9 inhibitor. And critically, statins don't lower LP little a. They may even nudge it up slightly, but they still reduce overall ASCVD risk, so don't withhold them. Now let's talk numbers. This is what actually moves LP little a. PCSK9 inhibitors lower LP little a by about 25 to 30%. That's a meaningful reduction on top of their LDL lowering effect. They're not indicated specifically for LP little a, but it's a real bonus. Lipoprotein apheresis, about 35% reduction per session. It's FDA approved for patients with familial hypercholesterolemia, documented ASCVD, and LP little a above 50 nanomoles per liter, and LDL still above 100 despite maximal therapy. And here's one that often surprises people. Oral estradiol. In postmenopausal women, oral estradiol reduces LP little a by about 37%. This is a clinically significant drop, but, and this is critical, this is a first pass hepatic effect. Transdermal estradiol does nothing to LP little a, so the route of delivery matters. So when a postmenopausal patient needs hormone therapy and has elevated LP little a, the oral route deserves serious consideration, weighed against her individual VTE and stroke risk, of course. Now for the exciting part, the pipeline. RNA-based therapies are about to change everything. These agents silence the gene in liver cells that produces LP little a, and they are achieving reductions of 80 to over 90%. Olpasiran is a small interfering RNA or siRNA. Phase 3 outcomes trials are underway. Subcutaneous injection every 3 to 6 months. Pelacarsen is an antisense oligonucleotide, also in phase 3. The Lp(a) Horizon trial results are expected very soon. Lepodisiran and zerlasiran are also siRNAs, and phase 2 and 3 data look excellent. Zerlasiran is advancing to phase 3 as well. And then there's muvalaplin, which is the first oral agent, a small molecule that blocks Lp(a) particle assembly. Phase 2 data published in 2025 looks promising. And if it pans out, we're talking about a pill that dramatically lowers Lp(a), and that would be a game changer. Now, none of these are approved yet. We're still waiting on outcome data to confirm that Lp(a) lowering leads to less cardiovascular events. But the field is moving fast. So here is the bottom line. Test everyone at least once. Repeat at menopause and with chronic kidney disease. If Lp(a) is above 125 nanomoles per liter, get the LDL-C as low as possible with statins, ezetimibe, PCSK9 inhibitors in sequence. In postmenopausal women, choose oral estradiol over transdermal to get that 37% Lp(a) lowering. And watch this space. Lp(a) management is going to be very different in 2 to 3 years. If this was helpful, follow for more evidence-based preventive cardiology and lipidology content. Thank you.